Syncope is a brief loss of consciousness, along with the loss of postural tone with spontaneous recovery. Most cases are indeed benign and are either vasovagal or hypotension related. Your main task is to differentiate a simple faint from other significant causes, primarily with a good history, examination, and sometimes an ECG. Let us look at a case scenario. Sarah is 8 years and was out shopping all day with her parents. She felt funny, looked pale, and next thing remembers being on the ground. History was also taken from mother, who said that Sarah went pale and slowly slumped to the ground. She also had a few jerks in all 4 limbs, but did not wet herself. The episode all lasted a minute, and Sarah had a mild headache afterwards. In the ED, examination showed a regular pulse, a blood pressure of 104/72 millimeters mercury, normal heart sounds with no murmur, and a normal neurological examination. What is your initial impression? Could this be a seizure? What will you do next? The next steps could include more focused history, wider history, consideration of differentials, perhaps consider a blood sugar and an ECG. This description that Sarah had a few jerks in all 4 limbs when she became unconscious. You can differentiate a seizure from a faint by following characteristics. Prodrome. Some seizures may have an aura, especially temporal lobe types. There is often a prodrome in fainting, and people begin to feel lightheaded, can have sweating or nausea. In some conditions, they have palpitations, not in a simple faint. A seizure generally comes out of the blue, but a faint is gradual and often comes over a few minutes, and others can recognize that a person is beginning to look unwell. Most seizures last about 2-3 minutes, but faints are shorter and generally half a minute or up to a minute. Motor phenomena like convulsions are common in seizures, but there can be a few tonic spasms, myoclonic jerks, or few twitches in faints also. Incontinence is seen commonly in seizures, but also seen sometimes in faints. Similarly, tongue bite is common in seizure and is rarely also seen in a faint. People in a convulsive seizure can go dusky or have a blue color. And in fainting, there is pallor. Someone who has had a generalized tonic-clonic seizure will have a slow recovery afterwards. But people after a faint would begin to interact almost immediately. Your assessment of a suspected syncope should lead to a conclusion that either this is a syncope or there is another possible diagnosis like a seizure, a migraine, a breath-holding spell, or someone who has had a hypoglycemia, etc. In syncope, you need to be a bit certain that is there a simple cause like a vasovagal, orthostatic, or a situational syncope, or indeed are there features of a worrying cause like a structural heart problem or a possibly abnormal heart rhythm related episode. Simple causes include vasovagal phenomena, where there is almost always a prodrome of nausea and sweating. Such phenomena are triggered by pain, anxiety, prolonged standing, or a warm place. Orthostatic hypotension can be triggered by someone who is dehydrated, has had alcohol, or any blood pressure lowering medications like diuretics. Situational syncope is seen along with micturition, cough, defecation, or carotid sinus pressure. Worrying causes of syncope are very rare, but you need to know about cardiac structural problems like right ventricular outflow tract obstruction, for example, what is seen in the hypertrophic cardiomyopathy, or left ventricle outflow tract obstruction as seen in aortic stenosis. Other worrying causes relate to cardiac rhythm abnormalities or arrhythmias, ventricular tachycardia being one of them, Wolff-Parkinson-White syndrome being the other, long QTC, and heart blocks. What are the key inquiries in history? A detailed account from those who have witnessed the episode, and also include what the patient remembers. You want to know the sequence of events, just like a seizure, what happened just before, during the episode, and afterwards. Describe the posture, duration of loss of consciousness, was there any stiffening or jerking, any contributing or precipitating factors, like has there been a recent illness, when was the last meal, how was the recovery, was it instantaneous or very slow, were there any associated worrying features like palpitations, dyspnea, chest pain, what is patient's medications, is there any known past medical history or family medical history of cardiac disease. Essential examination should cover pulse rate and rhythm, blood pressure both in standing and lying position, hydration status, a focused cardiac and neurological examination. Don't forget bedside glucose testing, especially if patient has come soon after the event, and also consider ECG in most cases. There are 5 red flags you need to remember for a child who has come with syncopal episode or recurrent episodes. Exercise-induced syncope, associated palpitations or chest pain, absence of any warning signs or prodrome, known cardiac history in the patient, family history of arrhythmias, or early or cardiac death. Other worrying features: if an examination showed an irregular pulse, or a heart murmur, or a significant postural drop in blood pressure, any focal neurological deficits or ataxia, prolonged loss of consciousness, or confusion after the event, which may lead to a different diagnosis. Also, finally, consider possibility of non-accidental injury in a young child or drug misuse in a teenager. Now, as we said, in most cases you would proceed to a standard 12-lead ECG. What are you looking for in that? Again, the important things you are looking out in a person who has come with syncope is PR interval. Is there a short PR interval with a delta wave? Could be suggestive of Wolff-Parkinson-White syndrome, leading to supraventricular tachycardias. Is there a long PR interval, which may be due to a type 2 or type 3 heart block? QTC interval, is it prolonged? And you have to consider, is it longer than 450 or 460 milliseconds in children? There could be congenital prolonged QTC syndromes, some of which are associated with deafness. Has there been any recent medication prolonging the QTC interval, like macrolides, some antihistaminics, and some diuretics? Look at the QRS complexes. Is there an increased tall R on V1 or a deep S on V5, V6, which may suggest right ventricular hypertrophy, for example in hypertrophic obstructive cardiomyopathy? Is there a tachycardia with wide QRS or ventricular pre-excitation or ectopics? Has there been a ventricular tachycardia or a bundle branch block? And finally, look at STT and T wave changes, which could be suggestive of acute myocarditis that can be viral in origin. Management principles for simple faints. Explain to the patient the nature of episodes and reassure. Identify and avoid any precipitants, for example, hot temperatures in the room. Teach self-management of symptoms. If patients recognize early warning signs, they should sit down, or if practical, lie down. This will also prevent injuries and redistribute blood flow to the brain. Lifestyle advice: maintain good hydration, avoid skipping meals, adequate salt in diet. If you are considering significant rare anomaly which may be leading to syncope, you may ask for specialist tests which are rarely required. These could include a 24-hour Holter ECG to catch any arrhythmic events. This is only successful in a small number of cases if the events are frequent. Some departments can also provide event monitor which can be switched on when the patient is having an event. Echocardiography could be considered if there is a heart murmur or if there is exercise-induced syncope. Exercise ECG testing or stress test could be also used if the echo is normal. These are generally requested by the cardiologists. And a tilt table testing can be used to confirm orthostatic hypotension.